and I'm so excited to be all here. And Amelia has a case. Thank you for presenting the case, Amelia. I'm from Brazil, and I am the 60 years medical student. I will graduate in December, so I'm so happy. And welcome, everyone.
I don't know if anyone can ever match Amanda's enthusiasm. We really appreciate you, Amanda. It's amazing. And yeah, welcome, Amelia. Do you want to say a quick hello before we jump into the case?
Sure. Hello, everyone. Thank you for having me. My name's Amelia. I'm a third-year medical student at George Washington University in Washington, D.C. And right now I am rotating at Sinai Hospital in Baltimore with some of the lovely people on this call. And I'm excited to be here.
Awesome, Amelia. We'll probably reveal the identity of said person in a minute, but we'll jump in and we'll start to reflect on your case.
Cool. We'll get the screen set up here. Okay. So to start, the chief complaint that we learned this patient was coming in with was AMS. And we were told more specifically that she was coming in unresponsive per her husband. So this was a 77-year-old female who presented with AMS. On the afternoon of her admission, her husband had noted she was less responsive, that is, she was just not answering any of his questions, but she didn't have any loss of consciousness. Initial evaluation in the ED was limited by her mentation, but at that time she was alert and oriented. She had pretty poor concentration, but she did not recall any prodrome or how long this altered responsiveness episode had lasted. She was able to maintain conversation, but then she kept perseverating on certain topics, specifically that there were alcoholics in her family. She denied headache, lightheadedness, or dizziness, fevers, chills, shortness of breath, nausea or vomiting, changes in bowel movement, or any changes in urination. We'll leave it at that for now.
What a well thought out and laid out story. Thank you so much. Amanda, what do you think?
So AMS, in this age, it's concerned because stroke, it's common, but I think I learned it here in CPSovers about MIST. It's metabolic infection or some structural toxin like use of drugs, alcohol, medication. In this age, it's important. So initially, this is my thoughts. And we concern about the age like malignancy for the neuro, né? Do sistema nervoso central in Portuguese, but I think like that.
I think that's absolutely superb, my friend. The way you're thinking is so reflective of how broad we should be. MIST is so many diagnoses, maybe 30 diagnoses. And I think I've been trying to explain this concept for a long time on VMR, and it finally made sense to me when I was watching my dog. I always talk about my dog, but what Amanda is doing right now is showing you that we still don't have a good handle on the problem. So in clinical reasoning, there are two phases to solving a problem, solving a case. One is understanding the nature of the problem to a high degree of certainty, and then beginning to solve the problem. So right now, Amanda is saying, all we really know is this patient is confused. There's so many things we need to know. The first is, what is her baseline? The second is, does she have any evidence of focal neurological features? The third is, does she have evidence of any systemic involvement of this disease process? And then, does any of those MIST things pop up? And if they do, the problem can turn into severe hyponatremia or a marked leukocytosis. So the problem can really change and define itself very soon. So what does my dog have to do this? I was watching him the other day, and the poor guy had lost his ball, which is devastating for him. Like when he loses his ball, his whole world is coming to an end. But the good news is he has a very, very savvy nose. So you can tell he's like sniffing. He's like, where is it? Sniffing. And there's a certain moment, usually 2 or 3 minutes later, where he like locks in. He's like, oh, I know exactly where it is. And no longer is he like chaotically moving, trying to figure out where the ball is. He's like on track. So right now, Amanda and I are just sniffing. And we know the world we're sniffing in is altered mental status. We will try to tell you when we are locked in, but we are very, very far from that, because metabolic, infection, structural, toxin is 100 things. So Amanda, let's keep sniffing, and hopefully Amelia can give us some more information.
All right. So the next bit of information here, we learned about her past medical history. So we learned she has hypertension, she has hyperparathyroidism, she has a history of HSV, and she has a history of ovarian cancer when she was 25 years old. She's now status post-hysterectomy and oophorectomy. In addition, she has a surgical history of a right hip surgery and a right knee surgery, but we couldn't figure out what years those were from. And then in terms of medications, she's on losartan and amlodipine, celecoxib, clonidine, hydralazine, hydrochlorothiazide, spironolactone, Bistolic, and Valtrex as needed for her HSV. She's allergic to penicillin and Percocet. And the family history, as noted from the patient, was that there was a history of alcoholism in her father and her mother. And then last bit here, so her social history, she lives with her husband. She formerly worked as a CNA, and she still likes to help and volunteer in her community. She drinks occasional moonshine, wine, and beer, and her husband says she last had anything to drink 2 weeks ago, and that was some moonshine. And then she doesn't have any tobacco use, but prior daily cocaine and heroin use in the 1970s.
Amelia, this is so thorough and so detailed, and I'm just in awe of Beatrice, who was able to keep up with all this. I can see you're working hard. Do you, Beatrice, any questions left for you? Anything that you weren't able to catch? Feel free to ask out loud so Amelia can give us that data.
Yeah, I think I may have missed something from the medical history, medical history, and the meds. I think I was greatly helped, actually. It wasn't just me. Deborah was doing a great job otherwise.
That's awesome.
Yeah, you're on it. You're on it. It's hyperparathyroidism.
Hyperpar, okay.
Yeah, but you got it.
Amelia, does the medication list look good to you?
I'm just
Maybe it was
here.
the
Valtrex, yep.
or some diuretics. Sorry?
Yeah, you got it.
So furosemide?
Oh, it was the hydrochlorothiazide and spironolactone combination.
Oh.
Okay.
I didn't know that came in a combo pill. That's cool. I thought it was always the ACE, but it's a good idea to come up with. It's pretty helpful. Amelia, thank you. This is really, really interesting background. It gives us a lot to work with. And I'm curious, Amanda, what thoughts came to your mind?
I just have a doubt. She denied change of urination, or she had change of urination?
You clarifying? Yeah, she denied any. And from what we could see in the ED, there was none.
Okay. So it's a lot of medications, huh? And I think in the past medical history, so hypertension is important in this case because an hypertension crisis can be with altered mental status. It's a thought here. Hyperparathyroidism, when it's not equilibrated, can be with AMS too. And in these medications about hydrochlorothiazide, it's a crazy. Everything can cause this chief complaint of this patient. Here, I'm not help, but not help yet. I think it's that, and the prior use of drugs, cocaine, it's very important. I think can be some toxin, drugs in the patient.
I think that's absolutely superb, man. It goes to show how when you learn all this history, you can be paralyzed because there's so many potential causes. So let's just remain practical in what happens in real life. And in real life, you have 3 priorities right now, 3 of them. The first is a very good neuro exam to make sure you are solving the right problem. Altered mental status is very different than altered mental status with focal neurological findings. So you have to make sure she's not having neglect, not having visual loss, not having focal motor or sensory findings. That's priority number 1. Priority number 2 is to look at her respiratory rate and consider Narcan if it's low. And priority number 3 is to get a finger stick glucose. That's it. And then only after you go through those steps can you start to analyze this data. So right now, we have many other things to potentially connect the syndrome to, but practically have to be rooted in those 3 arms: focality, Narcan, glucose, and we'll see what happens. All right, Amelia, tell us more, please.
All right, so on exam, so her vitals on admission, temperature was 36.7 Celsius. Her heart rate was 72. Her respiratory rate was 17, and her blood pressure was 157 over 124. On exam, so general, she was in no acute distress. Her extraocular movements were intact. Her pupils were equal and reactive to light. Her conjunctiva were pale, and there was no scleral icterus. Her oral mucosa was dry, and there was no noted thyromegaly or lymphadenopathy in the neck. Cardiovascularly, she had a regular rate and rhythm, no murmurs or gallops, and no peripheral edema. Her lungs were clear to auscultation bilaterally, and she was breathing comfortably on room air. Her abdomen was soft, non-tender, non-distended, no masses noted. Neurologically, she was alert and oriented times 2 to 3. So she could say self, place, and then she thought the year was 2022, but this was also January of 2023, so a little wiggle room. She had no focal deficits, and cranial nerves 2 through 12 were all intact. Her concentration was poor. She was unable to spell the word world backwards. And she had poor short-term memory to earlier that day, but good immediate memory from her time within the ED. In terms of her cognition and speech, she was clear and coherent, but spoke slowly. And she perseverated on topics, as we mentioned earlier. And then in terms of her extremities and skin, no deformities noted, and her skin was dry.
Yeah, wow. I mean, there's 2 things. One, this is such a detailed exam and very, very thoughtful. But actually, what stands out, I think, to me and maybe other people is watching how you're responding to this novel experience. I think you picked up on the fact that the scribe may not be able to keep up with you, and you're so deliberately thoughtful about presenting the next aliquot. So cool. That level of emotional intelligence is very impressive, especially when there's so many people watching. So kudos to you. Amanda, we're being slowly guided, but I don't know. I don't think I'm ready to lock in yet. What are you thinking?
Yes, I think too. But here I am concerned with the pressure. I don't think it's a neuro problem. I think the increase in depression causing AMS or something else, drugs, alcohol, medication, is causing the increase in depression. It's a doubt that I have. And I think it's emergency, hypertensive, here because of the blood pressure, but other signs make me relax. Do you know?
Oh, 100%. I think what the number 157 systolic blood pressure isn't that impressive. However, a diastolic blood pressure of 124 is pretty high. And that very narrow pulse pressure is very, very intriguing to me. But I think whenever you have hypertension and you have a symptom, you have to be very careful. Let me tell you a story. A patient came in with shortness of breath and was markedly hypertensive. And folks made the mistake of assuming that the hypertension was the cause of the shortness of breath and lowered the blood pressure. It turned out the patient had a pulmonary embolism and was in pain. And lowering the blood pressure was a big mistake in a patient with a pulmonary embolism. So when you have hypertension and you have a symptom, what you have to do is you have to translate that symptom into a specific diagnosis, which may or may not be related to hypertension. So Amanda, if we turn this hypertension and the symptom of AMS into hypertension plus hyponatremia, all of a sudden the blood pressure becomes irrelevant. So I think that right now we don't know what the altered mental status is, and it could be equally related to the blood pressure or equally unrelated, and we have to try to understand what is the nature of altered mental status. However, it takes some time to understand what the symptom and what diagnosis that represents. So you have to make your best judgment as to whether you want to empirically treat the blood pressure while you go on that diagnostic journey. Most people with altered mental status and hypertension have another diagnosis that got them to be confused, and they stopped taking their medication as a consequence of the hypertension and the altered mental status, not as the cause. But I think you're onto something. When you have narrow pulse pressure and a hypovolemic exam, as manifested by the dry oral mucosa, you could easily say that she's dehydrated and has increased vessel clamp. Why would she be dehydrated? She's not having nausea. She's not having vomiting. It's weird, but she is on medications that can dehydrate her. So for me, I'm starting to wonder whether this may be a medication effect, either because of the diuretic or because the diuretic causing water loss, or the diuretics potentially causing hypercalcemia in a patient with hyperparathyroidism. So a lot of things to use. The labs will be very, very informative, but I will caution all of us to be careful about hypertension and symptoms. Turn the symptom into a specific diagnosis. And if that diagnosis is a consequence of hypertension, that's hypertensive emergency. If that consequence is unrelated to hypertension, it's probably that the patient missed their medications because of that other diagnosis. All righty, Amelia, tell us more, please.
All right, so for the labs, her CBC, her white blood cells came back at 5.7. Her hemoglobin was 13.4 and hematocrit 40. Her MCV and MCH were normal. Her RDW was 15.7, and her platelets were a little low at 142. For the chemistry, her sodium was 138, her potassium was 3.5, her chlorine was a little low at 96, her CO2 was 31.2, her anion gap was 11, her BUN was 15, and her creatinine was 1.59. Of note, her baseline was 0.9. Her GFR was 34. Her glucose was 96. Her calcium was 9.6. I don't have phosphate for you here. Her albumin was 4.7, and her total protein was 8.1. Her total Billy was elevated at 3.1. Direct was 0.8, and indirect was 2.3. And then her alk phos was 42. Her AST was 31. And her ALT was 9. Just giving you a sec here. Then we also got urine on her. So in her urine, it was notable for a leukoesterase of 500 with negative nitrites. Billy was +1, heme was +1, protein +2. pH was 6. There was 1 hyaline cast noted per low powered field, 5 RBCs, 49 WBCs. And then regarding urine lights, she had a urine creatinine of 491. It was elevated. Urine sodium of 56 and urine protein of 126. We have a few more labs. Do you want me to keep going or pause for now?
Why don't we just reflect on these real quick, Amelia? Amanda, I'll just ask you a few questions, okay? So when somebody has acute kidney injury, AKI, what do you normally see the potassium? What happens, high or low? When in general, not this case, just in general, you have low creatinine, what usually happens to the potassium? High.
Hi.
Okay, another question. In a patient who has AKI, what usually happens to their CO2, high or low?
CO2.
Bicarbonate.
Bicarbonate. Ask in the another way.
Okay, so this number after chloride, you see it?
Yes.
Here it's 31. When patients have acute kidney injury, what do you normally see? High or low CO2? Do you know? Yeah.
Low.
The most
Yes.
common pattern of patients, electrolyte panel in patients with kidney injury is a high potassium and a low CO2. Look at this. Do you see it? The patient has AKI, creatinine almost doubled, and their CO2 is high and their potassium is low. Right?
Right.
You know what my dog would do now?
I'm crazy. So your dog, I don't know.
What caught your eye? What caught your attention in these labs? What did you pay attention to?
So I have a doubt. This anion gap is right. It's
It's normal.
height.
No,
It's
no.
normal.
Yeah.
Mm,
Normal anion gap is between 8 and 12.
oh yes.
Yeah,
Really,
so it's
yeah.
normal.
Normal.
Almost. I wish that was a clue. That would be very helpful.
So the patient had explained the symptoms with the labs with AKI, it's acute kidney disease, and can be because of the medications. I think clonidine, hydrochlorothiazide, I don't know how to say in English, can be this renal function and can cause the chief complaint of the patient. In the labs, it's in consonant, it's right with this, you know?
I think there's something really weird going on. I completely agree with you. 100%, we have not found any obvious cause for the patient's altered mental status. What we have found is something good for you to learn now. I don't think you've ever learned it before because it is very rare. And so let me teach you. When the CO2 is high in a patient, like it is here, the most common cause is the CO2 is rising as a compensatory mechanism for lung disease. So the lung CO2 goes up, so the serum CO2 goes up to compensate. If you look at her history, there's no history of chronic lung disease. That makes it much more likely that this CO2 is rising as a primary issue rather than a compensation issue. So why would the CO2 rise? 2 reasons. You're taking in too much bicarb. The best example is milk alkali. Another example is when people eat baking soda, which they shouldn't do, but sometimes do. There's no history of ingestion here. So it's very likely that the patient is making bicarbonate. There's only one molecule that makes bicarbonate in the body, and that's aldosterone. What else does aldosterone do? It increases the blood pressure. Look at that, blood pressure is high, and it causes potassium wasting. So I think you can say, I have altered mental status as one problem. I have excess aldosterone as a problem, and I have indirect hyperbilirubinemia as a problem. All these things need to be clarified in some way, shape, or form to come to an answer, but I think it would be a mistake to try to put them together now. So I agree with you. No clear answer for altered mental status. Let's hold the indirect hyperbilirubinemia. And now in the future, when you see increased CO2 and low potassium, think high aldosterone. That is a pattern that is very worth remembering. It is so unusual to see that pattern in the face of kidney injury, which usually does the opposite. Any questions about that, Amanda?
No, it's super clarified. I want to explain like that, but I have some difficulty with the English.
No problem. No problem at
But
all.
I really understand. Thank you for teaching me.
Please don't ask me to explain this in Portuguese because I will fail. So I appreciate it. All right, Amelia, tell us more, please.
All right, so a few of the other more miscellaneous labs perhaps that we had ordered too. So her LDH was notably high at 346. Ammonia came back at 17.6 and troponin was 9. We had also looked at some more values in her blood. So her retic count was 0.04, which is just a little low. Haptoglobin was 48. And then we ordered an ADAMS 13, thinking about DTP, and that hadn't come back initially. That one takes a little while. Eventually it came back as 84, which is within normal limits. Her U-tox was also negative, and her ethanol level was less than 10. Her PT was elevated at 14.7, just a little bit, and then INR was 1.1. We also had gotten a VBG, and pH was 7.44. PCO2 was 44, PO2 was 41. O2 sat was 73%. And then we got a peripheral smear. So her anemia had no specific morphologic abnormality, negative for schistocytes, negative for platelet aggregation or platelet satelitosis, and notable for thrombocytopenia. And then her imaging came back with no acute findings on head CT, chest X-ray negative for any acute pathology. And then her EKG showed sinus rhythm with some PVCs and non-specific flattening. It was somewhat low voltage. This was consistent with her prior EKGs. And I'll pause there.
What do you think, Amanda? Any clues that jumped out to you?
Yes, we have acidosis with the pH and increased PCO2. So it can be a respiratory acidosis.
Amanda, I thought just make sure we're not making the number is wrong. Is it 7.44 or 7.14?
4-4.
44.
Yes, I was typing that.
It's normal.
Yeah.
Okay.
So it's actually for venous, it's actually high. So venous is 7.44. So arterial would be 7.5, which is high. So the patient has alkalosis.
Alkalosis, yes. And alkalosis. So I think we can exclude some hair change in the neural symptoms about the CT. And I think that this LDH, it's high. okay? Or normal? It's
It's a
low.
little bit high, like 10% high. Not that high, but a little.
Not high. Oh, okay. So it's insignificant. I think it's that.
Amanda, this is a very hard case. I think right now, I think I have no idea why she's confused. I'm very happy that the workup is so far unrevealing. And the only clue we're getting is now confirmed metabolic alkalosis. So how do we know that? The pH is high and the PCO2 is high. So that must mean the PCO2 normally lowers the pH. So this patient has a metabolic alkalosis. The first step in metabolic alkalosis is to look at the urine chloride to help you determine if it is chloride sensitive alkalosis or chloride resistant alkalosis. And that will be very important. However, in this patient, she takes some diuretics, which will make it hard to interpret that test with confidence. So her blood pressure being high is a good proxy. Hypertension correlates more with high urine chloride. So I think the question really is, why does this person have high aldosterone? The problem, unfortunately, is that the overlap between high aldosterone and altered mental status is not something that is very obvious, apart from maybe some ingestion or maybe some renal vascular injury. So I'm really curious what the team did next, but I think this is a good exercise in alkalosis. So high bicarb, you check a pH, the pH is also high, so you have a metabolic alkalosis. And the first step with a metabolic alkalosis is to say, what is the urine chloride? Is it low chloride or high urine chloride? That helps a lot. But here with the data we have, the presence of hypokalemia and the presence of hypertension suggests that the chloride will be high. And that is a aldosterone excess problem.
I have a doubt quickly, Rabih. And we have the urine calcium in the urine, because thinking about metabolic alkalosis and using diuretics, I think two pathologies, and the urine calcium help us. I don't know how to say in English, but is Bartter syndrome and yes, syndrome. So I think it's helped here.
I agree with you. If the patient were younger, or if the patient had lower blood pressure, because hypertension is unusual, that would be a very important thing. Barter and Gittleman, for sure. What if you are on CP solvers, what you should look at is the inappropriate aldosterone schema. I think the answer is somewhere there, including Barter and Gittleman, but I don't know where. All right, Amelia, tell us more, please.
All right, so I think this next bit is going to give it away. Are we ready for that?
Absolutely.
Okay. So first I'll say that her renin and aldosterone levels came back and they were both within normal limits. And then we got thyroid levels. Her TSH was found to be 258.3. Her T3 was less than 0.2 and her T4 was less than 0.1. So she was found to be in severe myxedema crisis.
Amazing. Amanda, what do you think?
I missed the T3 and T4, sorry.
I think the T3, you can just, yeah, thank you, Bia, for asking. The TSH is very, very high and the T3 and T4 are low. I think that's all you need. Yeah. What do you think, Amanda?
Oh my God. I never. So this case, oh my God, I learned so much. Myxedema crisis, very interesting. And we learn a lot from this case about the labs, about the chief concern. Oh, I'm shocked.
I know, I am too. I'm curious, Amelia, what prompted you to get the TSH and how did you connect that? Was it for altered mental status or how did you sniff this out?
It was part of our initial altered mental status workup, and it just hadn't come back early on. So we spent the full day going through the same things you're going through. And it came back much later than some of the others. So, but initially it had been, we were thinking through, we actually had used the MIST. And so we were thinking through, like, she has the hyperparathyroidism and thinking about like endocrine abnormalities.
You know, I think that it's so important to be as detailed as you were to like send all the tests for altered mental status and go beyond that. I worry that I might have missed this in real life because, gosh, it's so easy to forget to click that TSH and that 3T4. And honestly, at least for me, I may come up with ways of refining my thinking, but I'm not sure that that hypothyroidism crossed my mind. Amanda, did it cross your mind?
Totally. Oh my God. I am just thinking about this disease in the whole exam. Oh my God.
You know, I think the only real finding outside the coma part, which is very prominent, is the blood pressure. There's no hypothermia, there's no bradycardia, there's no hyponatremia. There's an indirect hyperbilirubinemia. You know, the acid-base issues that you can get with mixed edema coma are a respiratory acidosis from hypoventilation. Everything is so slow that you slow down and you even stop breathing. And so you might have expected a respiratory acidosis rather than a metabolic alkalosis. But do you think, I'll ask you, Amelia, and anyone who else who was involved in the case, do you think that there were any other clues that you all were able to retrospectively fit in with hypothyroidism?
So one thing that stood out to me was actually when you just mentioned about the blood pressure, or I think it was in the chat, that the diastolic blood pressure being so elevated is a sign of hypothyroidism. And I think because of this case, now every time I see that, I'm going to think of that. Another thing that was very helpful is that her family then alluded to her being status post-ablation for Graves. And so that makes me feel better too, that this would not have been something missed if MISSED, if we had not ordered the TSH originally.
Absolutely, it was right there, that piece of history. That's right.
Yeah, which raises the whole compliance point, like adherence to medications, which someone else had raised in the chat, and we knew that she wasn't compliant with her blood pressure medications. Her family also told us that. So now it seems she was also not compliant with any thyroid thing.
Yeah, you know, this is an incredible case. If you are beginning your journey in medicine and you hold up a textbook where it has a description of hypothyroidism, and then you look at this case and you're like, wait, there's no way it can be. There's no constipation, there's no reflex changes, there's nothing. And I think it goes to show you how complicated medicine is and how diseases can show up at your doorstep. And this is why some of us who are invested enough to show up every single day to practice and practice and practice. And we're very grateful for you, Amelia, for giving us this opportunity to refine our to find our way to learn and grow. Amanda, how did you feel doing this?
I am with tachycardia here because of this case. It's totally new for me, and I hope to study. And medicine is very crazy, but it's very beautiful too. And I'm happy to be part of this case, a complicated case.
Yeah, it really, really was. I love your attitude and approach. I think many people would be sad that they didn't get it right. And I think it's just so admirable to see you learning just to be healthy about your growth. And I am too, you know, I'm not disappointed at all. It's really cool to feel that, you know, to not feel that and to be excited to learn and grow. All righty, well, Maddie, I don't know what any of our teaching points have anything to do with the final diagnosis. Please take it away.
It was still an amazing journey. Amanda, really fantastic job at discussing this really, really tricky case, and Amelia with just incredible job presenting. It was such a thorough presentation. Okay, so at the beginning, we kind of just started at a high level that clinical reasoning has two phases. The first is understanding the nature of the problem, and second is solving the problem. And at the beginning, with just the chief concern of altered mental status, we're very much still trying to understand the nature of the problem. So we can use the very broad MIST mnemonic, which includes metabolic, infectious, structural, and toxin causes. But really, when you just have that chief concern, there's a lot of additional information you need, like what is the person's baseline? Is there evidence of focal neurodeficits? Is there evidence of systemic involvement? But really, in real life, there are 3 priorities you need to think about when presented with altered mental status. You need to do a neuroexam to determine if there's focal neurodeficits, look at the respiratory rate to consider if you need to give Narcan, and then look at a fingerstick glucose. So then when we got to the vitals, we learned that the patient was hypertensive, but it had this other symptom of altered mental status. And we learned that you really need to translate that other symptom into a specific diagnosis, which may or may not be related to the hypertension. So as an example, if this other symptom is unrelated to the hypertension, like hyponatremia, for example, maybe the patient missed their medications, their antihypertensives, which could be causing the hypertension. And then the labs, we had a really interesting discussion about the potassium and the bicarb level in the setting of AKI, because usually the potassium is high and the bicarb is low in the setting of AKI, but that was not the case in this case. So when the bicarb is high, the most common cause for the bicarb rising is a compensatory mechanism for lung disease, but there was no lung disease in this case. So then we thought about it being a primary issue. So you can ask the question, well, why does bicarb rise in the first place? And one way to think about it is it from ingestion, like milk alkali syndrome, or from baking soda even? Or do you kind of have excess production of bicarb from aldosterone? So really, you should be considering, excess aldosterone. You should suspect that when there's high blood pressure, low potassium, and high bicarb. And that was, we kind of further went down that path and we saw a metabolic alkalosis with a high pH and a high bicarb. And we learned that you kind of as a first step when exploring metabolic alkalosis, you want to look at the urine chloride to see if it's chloride sensitive or resistant. And usually hypertension correlates with a high urine chloride in the setting of high aldosterone. But we ultimately, had a kind of a really surprising ending here with myxedema crisis and hypothyroid, which I was definitely not expecting. And so I think it seems like a clue was the history of this recent ablation that the patient had. But really altogether a surprising case, but a lot of really fantastic learning points along the way.
That was an incredible recap. Absolutely amazing. Thank you. Thank you, Amanda, for co-discussing. It was such a treat as always. I love your enthusiasm and your growth mindset. And Amelia, I don't know what to tell you, but to take it back to my dog, because that's what I always do. I feel like you just gave him a new ball. Like I'd never, ever heard of this, never even made the connection of hypothyroidism here. And I'm really excited to reflect on it. And I really appreciate you bringing it here today. We hope that you enjoy the rest of your rotation with Franco and all, and I hope to see you on VMR in the future. All right, everyone.
Thank you.
Have a great day. Thank you.